Our routine at the University of Pennsylvania is to suture the endotracheal tube in place. I'm going to do that through the nasolabial fold. Make an air knot. And then suture the tube off to the side. A second suture that's useful to place is a tongue suture. This is done as a half mattress placed in the tip of the tongue. In this model, the tongue can't be retracted fully, but what this allows for is retraction of the tongue to the left or the right during the case while you're placing the mouth gag. An important consideration when you're placing this suture is to do it as a half mattress suture so you don't tear the tongue while you're retracting it, but also place a hemostat and leave it long as a reminder to take it out at the end of the case. A third suture that can be placed is a suture intraorally to hold the endotracheal tube laterally away from the operative field. Again, we don't cut this suture, but we place a long segment of the stitch with a hemostat in place to remind us to remove it at the end of the case. The next step is placement of your Crow-Davis mouth gag. So when you're placing the Crow-Davis mouth gag, the key is to utilize your stitch that you had placed through the tongue to either retract it to the right or left and to pull it away to get better exposure. Put on a headlight, which is at the patient's bedside. Pass it intraorally, and as you would in any standard case, open up the Crow-Davis mouth gag. Then you use your Stort's scope holder, attach it under the mouth gag, and tighten it. And this gives you excellent access to the palate, tongue base, and tonsillar area. The next step, the nurse has fashioned two red rubber catheters in a Y suction device that can get attached to the suction on the Stort's tongue blade that allows for smoke evacuation during the case. When placing the FK retractor, pick out the blade you want to utilize depending upon the exposure you need. This particular blade is excellent for supraglottic resections. This blade is excellent for access to the anterior commissure. These blades allow exposure of either the right or the left tongue base. And this is an overall good blade for exposure of the supraglottis as well as the tongue base. When placing the FK mouth gag, I find it more useful to use a headlight than the light source that comes with the FK. So again, the suture that's been placed in the tongue can be used to move the tongue in a position that works for the exposure of the disease you're looking at. We put a tooth guard in place, which we use a white plastic tooth guard, and then place the upper blade over the upper teeth, being careful not to constrict the tongue. And then we slowly open, and under direct vision we can see the anatomy we need to expose. And then once you're in position, you take your chest support and you put it into position to hold the FK in a stable position. And utilizing this mouth gag, we get excellent exposure of the larynx and hypopharynx. Now, an alternative setup has to be utilized with the standard Da Vinci, because with the standard Da Vinci, you can't put a Mayo stand in because the arm articulates in such a way that it's close to the chest. So the alternative approach is to not utilize the chest support and not have the Mayo stand in place, but instead utilize two Storz scope holders that are tightened into position. And you'd have one on each side of the bed, and that would be sufficient for holding your mouth gag in place.